The purpose of this podcast is to discuss the functional needs that an ophthalmology practice has for computerized medical records. Many ophthalmologists are early adopters, and over 30% of single specialty ophthalmology practices are already using computerized medical records. However, the vast majority of these are single specialty systems. As large medical centers and multi-specialty groups transition to electronic health records, ophthalmology is sometimes a holdout department that's hard to bring on board. The reason for this is that ophthalmic practices have unique functional needs for electronic records. So the purpose of this podcast is to take a few moments to understand what these unique needs are. We can group the problems in an ophthalmology practice into three categories. First, those surrounding manipulating eyeglass prescriptions, getting a patient's eyeglass prescription into the chart, and then getting it back out into a prescription to give the patient. 2, unsupported workflows, and 3, a group of specialized ophthalmologic tests that are mostly digital imaging tests. This is a relatively straightforward prescription for a pair of bifocals. The information is not complex, and you can imagine how a program dedicated to ophthalmic workflows could be configured to capture this data in a structured format. A multi-specialty EHR, however, lacks specific fields for eyeglass prescriptions. While this is not exactly a patient safety issue, it can be a big dissatisfier when your eye doctor can't even get your eyeglass prescription correct.
This is the lens meter that you're showing me.
Correct.
And that's how you determine what the prescription is in the glasses, right?
That's correct.
Yeah. So when a patient comes in, they give you their glasses, and you want to get their glasses prescription in the chart, right?
That's correct, yes, sir.
So
I just put it right here, and I read their prescription.
Let's look at how dictating an eyeglass prescription can add to the workload for the eye doctor, and even worse, make the data less accurate. In most practices, the patient's eyeglasses are read or neutralized by an allied health person, usually called a technician. The technician writes this in a paper chart. We went through a period a few years ago where we actually attempted to dictate the eyeglass prescriptions into our computer system. This is particularly a problem if the patient has multiple eyeglass prescriptions. The telephone dictation system went to a digital transcription pool where prescriptions were typed into the electronic record with all the plus signs and minus signs. As you can imagine, with no context to the numbers, the transcription error rate was very high. We had to abandon transcription rather quickly and eventually found a third-party device interface that allows for direct entry of eyeglass prescriptions into our computer systems. However, since there is not an HL7 standard for eyeglass prescriptions, identity maintenance is a constant challenge. Like many surgical subspecialties, ophthalmologists see many patients for short visits. Where a visit with an internist might last 15 to 60 minutes, the eye doctor may have only 5 to 20 minutes to spend with the patient and complete his documentation. In order to keep up, some of the data gathering is often delegated to a technician who may check the vision, the intraocular pressure, or, as we've already discussed, may check the patient's eyeglasses. This rapid workflow with data being gathered by more than one person can only be done efficiently with structured documentation, so we strongly recommend a single power note that is modified for ophthalmic data capture. The third area where ophthalmologists seem to have problems adapting to general medical records is due to the large number of tests that are routinely done in medical center ophthalmology practices. These include retinal pictures, ocular ultrasounds, visual field tests, and laser scans. The amount of digital imaging routinely done in an ophthalmology practice requires almost a small picture archiving and communication system, or a miniature PACS, much like a radiology system. For this reason, many ophthalmology-specific records have some sort of provisions for storing and displaying images, although rarely is this adequate. This becomes a very difficult area in that some current devices are not DICOM compliant, and even more legacy cameras and ultrasounds are non-standard. Unfortunately, most practices continue to acquire imaging devices without a plan for how this equipment will interface with the medical record or even how images will be securely stored. The approach we have adopted is to interface as many of the legacy devices we have as possible and to make provisions for local storage in those areas where integration with PowerChart is impractical. We also require all future purchases have a technical analysis. In summary, if you are having difficulty rolling PowerChart out to your eye department, consider that ophthalmology has unique functional needs that may represent gaps in your current EHR configuration. Areas to look at include how eyeglass prescriptions are being captured. Is the ophthalmology workflow supported? And is there a reasonable procedure for handling digital images in the department? Ideas to help address these deficiencies may include allocating resources to support using PowerNote and discouraging dictation as a method of documentation. Even consider allowing scanning of handwritten eyeglass prescriptions as an interim solution. Make sure that the department has a strategy that allows techs to enter data directly into PowerChart and ideally allow direct flow sheet entry of intraocular pressures. Create a PowerNote for eyeglass prescriptions that is formatted so that it can be printed out and handed to a patient. And finally, work toward a solution that safely and efficiently stores and reviews digital images, except that some devices may need to be operated in a standalone capacity as an interim solution. Thank you very much.